Good morning, everyone. We'll kick off the morning session. This session is on the management of atrial arrhythmias, and the first speaker is Dr. Ralph Damiano from Washington University, St. Louis Barnes Jewish Hospital. We'll speak on ablation technologies. Ralph?
Thanks, Tom, and good morning. So I'm actually going to give you the first two talks, so I hope I don't get you too bored. If anyone has any questions during it, you can raise your hand. I'll be happy to answer them. But I'd like to first start by reviewing what the present options are, ablation technologies, but particularly focusing on how they work, which often doesn't get, I think, enough attention, and what the experimental data suggests about their efficacy. And then I will talk a little bit about how to do a minimally invasive maze. These are my disclosures. So, what do we need to do when we try to do surgical ablation for atrial fibrillation or any arrhythmia? Really, the principle is you have to create conduction block. And to do this, you have to really create a transmural continuous lesion. I remember in the early days of ablation, people were arguing about transmurality. There really is no argument about that. Unless you go all the way through the muscle completely and the lesion is completely continuous. For instance, if you're encircling the pulmonary veins, you have to make a continuous, sometimes the actual ablation line can be almost 10 to 12 centimeters in length. And even a tiny gap anywhere negates the whole line. And in fact, small gaps in lines are very proarrhythmic, and that's the model we use in the laboratory to create arrhythmias. So we've shown, and a lot of other labs have shown, that gaps as small as a millimeter. In fact, you can't make a gap small enough in the lab. I'm sure you could, but you really can't physically make one small enough to block either AFib or sinus rhythm impulses. So that's the first thing, and that is not actually that easy of a task, and I'll show you why that. Now, almost all the original surgical procedures for arrhythmias were done with these ablation devices, a scalpel and a pair of scissors. They're very good because it's pretty visual. You know when you've created a transmural ablation with these devices. Simple, they're both simple and cheap. Unfortunately, they resulted in some pretty difficult procedures, and while for those who remember, we used to do WPW and other types of arrhythmia surgery, and even ventricular tachycardia surgery, to do a maze, and this is the cartoon of the original Maze 3 that Jim Cox proposed back and first did back in 1987. This was a really formidable surgical procedure, and you can imagine doing that ablation line down around, and I'll see if my mouse works, this ablation line around the pulmonary veins was a difficult task. Now, that operation worked great. This is the paper we published in 2003 where we actually looked at all the Maze 3s, and we had follow-up of almost 6 years, and this was at last follow-up, but the mean follow-up was almost 7 years actually, and 80% of the patients were both free of AFib and medication-free. Now, that's symptomatic. None of these patients had any EKGs, but still pretty darn good when you have that type of long follow-up. And this was over 100 patients that were followed. So it worked well. The problem was no one did it because it was just too hard to do. And even it never was done commonly enough to even be included in the STS database. And only about several hundred procedures were being performed worldwide each year. And most of these, almost 90% of those procedures were done just at a handful of very specialized centers. So you could argue that it really, while it was successful in treating sinus rhythm, it wasn't successful at being adopted, which is probably the biggest hurdle for any major operation. Now, it's interesting, in 2000, that was the estimate, about several hundred. Last year, over 50,000 ablations were performed. So what happened in basically the last 15 years? And what happened was we took a complex procedure and made it simple. And we made it simple by using ablation technology to replace the incisions. That allowed the operation to be done more easily, and it was much more accessible to surgeons. It also by using ablation technology, instead of making all these myriad of surgical incisions, we were able to develop less invasive approaches. And initially, at the beginning of the millennium, there was a ton of different ablation devices. Microwave, laser, and HIFU have been taken off the market basically because they didn't work very well. And we're left in 2018 with two types of radio frequency, both unipolar and bipolar, and a mixed device, which I'll show you, which uses both, and cryoablation. By far, the oldest ablation technology is cryoablation, and the first arrhythmia procedure was done with a reusable cryoprobe that we still use, that was initially made by Cooper Medical, and it's been probably one of the better tested of the ablation technologies. So let's look at these and see what the data shows. And clearly, the one thing to remember is surgeons, when you listen to the sales representatives, is that good ideas don't always translate into clinically effective devices. And it's like this cartoon says, that you may have a lot of confidence, but at the end of the day, you need this thing to work. And the big issue was that almost all these devices were released on the market for just soft tissue ablation. In fact, even today, there's only the only devices approved are the bipolar clamp, and that's to be used to do a Maze 4. There's none. All the other devices are used off-label still. And not only they were approved without really a lot of experimental data showing that they were either safe or efficacious on cardiac tissue. And it led to actually, and we won't spend a lot of time, but a lot of these devices were really incapable of creating transmural lesions. And our laboratory spent really about 10 years looking at every device we could to see if they actually work. And it was surprising, a number of them did, and I'll show you some of our data. But you would think, well, how hard could it be to create a transmural lesion? Well, it's actually quite hard, and I think it's still a challenge 18 years later. The atrial wall, as we know as surgeons, really is variable in its thickness. It goes from anywhere from less than a millimeter to, in patients with, for instance, valvular heart disease, and particularly mitral stenosis, where you get some wall hypertrophy, up to almost 2 centimeters. The other thing is epicardial fat is the bane of all ablation, whether you use cryo or radio frequency. It has an incredible resistance and it blocks ablation. We're doing some work in the laboratory on that right now, but it's a real problem. And the other thing, if you're doing an off-pump beating heart case, is the heat sink of the circulating intercavitary blood pool really prevents you from from the epicardial surface ever creating a transmural lesion. It's really almost impossible. Unless you try to overcome that with some clever devices, which I'll show you some that try to do that. So let's first look at atrial wall thickness. This is just a picture of the left atrium, and you can see in, where am I? There's my little mouse. This is a cross-section in a pretty important area. Here's a left superior vein, the big lateral or Coumadin ridge, then the area between that and your annulus. This would be your mitral valve, and these are your vessels. But you can see not only is there some things you would like to avoid, like the left circumflex artery here, but there's also, look at the thickness here compared to the thickness here. I mean, you really go, like I said, from a centimeter to just a millimeter or so. And you can see when you transilluminate the atrium how thin atrial tissue is, and as surgeons, no one needs to tell us that. And this is the area, in the same area between the pulmonary veins, the lateral ridge, and this would be sort of the appendage and the valve over here. But you can see it's just a really anatomically complex area. And this is just looking at the right atrium, which is actually is much harder, especially from an epicardial beating heart standpoint, to ever create a transmural lesion because of all the trabeculae, which you can see here on this picture. And this just looks at one area, Bachman's bundle, which is an area that goes over the roof of the left atrium, and you can see it varies in thickness anywhere from, in patients with cardiac disease, anywhere from 3 to 1.5 centimeters, anywhere from 3 millimeters to 1.5 centimeters. So again, there's some really thick muscle, which makes doing complete ablation lines often very difficult. And when you consider that, just from an intuitive standpoint, it's pretty obvious that any device or any device that tells you they're just going to deliver a set amount of energy for a set amount of time, it's probably unlikely to work 100% of the time. It's just really hard. You're going to have to take into account that there's going to be some areas you're going to have to ablate longer. And then there's fat, and I won't spend a lot of time with this except to tell you it's really been a problem for epicardial cryo. It's a huge problem for epicardial unipolar RF, and actually even for the bipolar RF clamps if there's a lot of fat. And the problem, this is just a little look at it, is that this is an example of unipolar RF from a really nice paper that was done, but really showed that once you got a fat layer of more than 2 millimeters, you just don't even penetrate. There's no heat penetration into the tissue from unipolar RF. It can't get through it. Cryo is actually surprisingly similar. You cannot freeze through more than 2 millimeters of fat. It just doesn't. And I would tell you, when you'll get an ice ball, but that's really a surface ice ball. It doesn't really mean anything. So you really have to be aware of that. And if you're doing a procedure, try, if you can, to dissect some of the epicardial fat if it's a lot. And then finally, the last challenge is the heat sink of the intercavitary blood pool. And this is just an example, if you're ablating, particularly epicardially on a beating heart case, you have to first get through the fat, then the muscle, and then you have this blood going by at 4 to 5 liters per minute at 37 degrees. And you can see it's really hard to heat that endocardial surface. You have to heat it above 50 degrees centigrade. But if you have this blood going by, that's what we mean by heat sink. It's also a cold sink. It won't let it freeze either. And it was interesting. This is a device, and Sam and I were just talking about it. It was actually a quite popular device. Tens of thousands of ablations were done worldwide with this device. And this was probably in the 2005, 2008 range where it really became popular, big multi-center trials. Now, the irony of this device is that it actually worked incredibly. It's one of the best devices on pump ever. Unfortunately, they were trying to do this for minimally invasive beating heart, and that's where it totally didn't work. And that's because of the heat sink. And this is a good example of an experiment we did. You can see we published it over 10 years ago, but it's true for almost every device. And we did this on bypass on a bunch of animals, and we looked at full cardiac output of greater than 4 liters per minute, and this is on if you were on complete cardiopulmonary bypass, so you had no endocardial blood, you didn't have any intercavitary blood flow. And this is the percent of lesions that were transmural, and you can see, less than 50% at normal cardiac output, so it doesn't work with the heart beating. But once you emptied the heart, look, it was fantastic. And microwave is great because it doesn't char. It was a really cool energy source. Unfortunately, they took it off the market, but if they had just used it for on-pump ablation, it would have been fantastic. And it doesn't char. It's very reliable. And you can see even at low, barely any cardiac output, you get up over 90%, but you could definitely get 100%. We looked at actually longer. They needed a little longer ablation time than they wanted to. But this is something to remember. Epicardial and just the biophysics of it is it can't be transmural. So how do you overcome those shortcomings? And the first thing is there's a lot of ways to overcome this beating heart, but the unipolar devices we've tested have really been poor at creating transmural lesions. I'd like to show you this. This is a device that's still on the market. It's in contact now. It's marketed by AtriCure, but it's a unipolar irrigated suction-assisted RF device. And we tested this device, and this is what we found. So this device, this is lesion depth versus tissue thickness. And you're going to see this. This is how we look at devices, and it's a good way. If anyone tries to sell you a device, you should ask them to show you this curve. We have it for most of the devices. You'll see as we go on. And if a device was perfect, the lesion depth and tissue thickness would always be the same, and it would all fall on this line of identity. If you're below it, it's not transmural. And you can see this device doesn't work in thin tissue, it doesn't work in thick tissue, it doesn't work at 50 seconds, it doesn't work at 90 seconds, and it doesn't work at 120 seconds. It just is not a good device. And 18% of the lesions were transmural, which is the worst device we've ever tested. So, but it's amazing, this device has stayed on the market. This we published back in 2009. It's still on the market today. In fact, it's in part of a big multi-center clinical trial. We'll see. Perhaps there's other reasons why devices can work, but you'd think this is one of the basic things it should be. Now, another way they've tried to overcome, that companies have tried to overcome this problem with heat sink and thick tissue and fat is using a different type of ablation technology, and this is an epicardial bipolar device called the CoolRail, which has been very popular, and a lot of people use it in hybrid procedures. How does that work? Well, it works better than that, the unipolar device, but still has something. Now, this is the same plot of, and this was done, and this is a chronic animal study looking at lesion depth and tissue thickness, and you can see it actually works pretty well until you get about 4 millimeters, and then above 4 millimeters, you get a lot of non-transmurality. But 70% of the lesions were transmural, which I think is great. But when we looked at the animals at 30 days, none of the linear lines created conduction blocks. So it worked, you know, you're not just trying to, it's not the number of lesions transmural, you have to get the whole line transmural. So at least in our studies, the CoolRail wasn't capable. Even though it was much better at penetrating, it wasn't consistent. And remember, I've told you that if, for instance, if you're isolating all the pulmonary veins, you have to make this continuous, you know, almost 10 centimeter line with no breaks in it. It's really hard, and we could not do that with the CoolRail device. Now, there are ways to improve the CoolRail performance, and people do it clinically. We've looked at multiple ablations, and if there's any way you can reduce that intercavitary blood flow, I showed you with that microwave experiment, that will also help with penetration of an epicardial device. And this is just an example of from an experiment we did, and transmurality is put on the y-axis, and then we looked, and I probably would just focus on left atrial ablations, and with a single ablation with the CoolRail, we got about 70% transmural, and my little mouse is kind of going everywhere. Here we go. And then if we did even just one ablation more, we got up to 92%, which is better and certainly moving in the right direction. Also, we looked at caval occlusion to decrease the intercavitary blood flow, and you can see without caval occlusion, only 24% of the lesions were transmural, but with it, we could get up to 81%. So these are all little techniques you can remember that may help you, but you know, it's hard to do caval occlusion on people and a little easier on dogs. Now, the other way people have gotten away from this intercavitary blood flow is to use bipolar clamps, where you put a clamp on each side. Therefore, the electrode flow, the electric current flow is really shielded from the intercavitary blood. And those devices have worked great. These are the two that are presently on the market from AtriCure and Medtronic, and they both work a little bit different, but both really measure the conductance between the electrodes and decrease the device and stop the energy once you reach some stable low conductance. They work a little bit differently, but both I think have had good results both clinically and in the laboratory. And this is an example of a histologic section from a bipolar RF clamp, and you can see this is a trichome stain, and blue is scar. You can see how nice discrete transmural lesion you had there. And we published 5 chronic animal studies with both the AtriCure and Medtronic clamp, and we had 100% transmurality in animals. And it works quickly, and we didn't see any collateral damage. You'd see this is fantastic. But still, they have some drawbacks, and it's unpublished data, but in really fatty atrium, these clamps also, and there's something about human fat as opposed to animal fat that seems to be a problem for ablation, and we're working through some of that. But I would still say even the bipolar clamps, if you have a lot of epicardial fat, can be fooled. The problem was our experimental work was not totally consistent with our clinical findings with the first bipolar clamps, in that the good example, again, this worked great in animals, but we didn't even take that for granted. In every case I did with the initial bipolar clamps, we would check after every ablation to see if we had exit block. That is, we had created a transmural lesion. And what we found, which surprised us, is it took on the right veins an average of about 3 bipolar clamp applications, and on the left side, 3.1. And we were thinking, it was a little astounding to me because in animals, we always had exit block with 1 ablation. So we knew that we were dealing with, and right now we're still trying to investigate some of that, but I think most of that is due to the fat. But there's also a much more effective device that was developed this is the Synergy clamp, which has 2 electrodes, and it oscillates the energy between the 2 electrodes. And this is a device by AtriCure, but you can see when you compare the old device, which gives you a smaller and more hourglass lesion, this was a bigger lesion and also had more consistent energy delivery through the tissue. So it really was good. And this is just a study we published comparing the original to the present, which is the Synergy clamp, and that showed that the ablation line was much wider, and both were very effective in animals. The only technical tips that I'll tell you when you use these bipolar clamps is it's really important not to bunch the tissue or have a lot of fat, or you don't get an effective ablation. And just remember that whichever the bipolar clamps you use, they're controlled by algorithms that are based on the conductance between the electrodes. And you have to avoid anything that will really decrease conductance or increase resistance. And the things that can do that are air, fat, and if you let any char get on the electrodes, the clamps will stop working. And the other problem with the clamps is you can't do a whole maze with it. You can only do pulmonary vein isolation. So to perform a maze, you can't perform a maze with just bipolar clamps. You can't. There's no possible way. And I've tried to do it. You can perform less than a maze. You can perform pulmonary vein isolation, but you can't perform a maze. So you have to have another technology. Now, one of the promising other technologies, and this is a paper we published in 2013, on the fusion device, which was with ESTEC and now is also by AtriCure, uses a combination of both unipolar and bipolar energy. And that device, you'll see, of all the devices from the epicardial surface, worked the best. And this is the paper we published on that. You can still see that it's not perfect, and you can see there's still some ablation histologic sections below the line of identity. But you can see it, you can remember the cool rail was 77%, 94% now are transmural. We're getting probably to the limits of what you can do from the epicardial surface. Still though, a third of the ablation lines conducted when we came back and checked. So it just goes to show you need a device that's probably in the 98, 99% range to really consistently get block. So what have I've shown you none are perfect. To complete a maze, we tend to favor cryoablation, and the results with that have been excellent. And these are some of the probes that have been used, both the disposable and reusable probes. And I probably won't show you, we've looked at both the AtriCure and Medtronic, and they both work extremely well endocardially on the rested heart. And I'll just show you some of the data, but they're equivalent. Epicardially on the beating heart, neither work very well from the epicardial surface. This is looking at the reusable probe, which we still really like in St. Louis. And you can see, again, the same curve. These, you have to wait 30 days to do the histology because cryo lesions expand over time. But you can see they tend to work virtually well, and we were very happy to see the Cryo 1, which is the disposable. Now it's the Cryo 2, and I'll show you the last generation. They all seem to work very well, and you can see the only non-transmural lesion, 1, which was in an incredibly thick area. 99% of the samples were transmural, and we did 2-minute ablations. Because of this data, because it wasn't 100, I tend to do 3-minute ablations clinically. And this is the latest device by AtriCure. It's called the Cryoform, also uses nitrous oxide. And we published last year this device on a chronic ovine model. And I won't bore you with everything, but this is the final thing, the same slide you've seen. A little different color background, but you can see most of the histologic sections fall right on the line of identity. And this was 98% transmural. And really the only ones that were at the very ends in really thick tissue, and you probably need to overlap this device just a little bit. And we do, because of that they're not quite 100%, we tend to go 3 minutes at minus 60 degrees centigrade. And the only thing I'll say for those of you who use the probes, you have to have complete contact, that even the tiniest gap between the probe and the atrial tissue will result in an incomplete line. And I think that's the reason some people don't get as good a results with cryo as they could. But if you're compulsive, it's a fantastic device. And then the only little thing I would mention is, coming to the end of my time, is that you really, with cryo, you don't want to re-rush the rewarming. A lot of the tissue death occurs like that, so have a little patience. It's hard for me. As some of you have seen me, I usually don't have enough patience there, but I do think about that. And it's very safe around valve tissue and the coronary sinus. And with the original cut and sew maze, we froze the coronary sinus in every case because we had a lot of reconnection there. And we've always frozen over valve tissue. It really is safe, but it is not safe on the coronary. So I just would not freeze a coronary. You'll get late intimal hyperplasia. There's been a lot of studies on that. So I'll end with this quote from Robert Frost, because I think it sums up. I mean, all the devices used well can work. It's just a challenge, and you have to remember the advantages and disadvantages of each device. I do think both radiofrequency and cryo can work very, very well, and can become, either one could really give you a great ablation strategy to take care of arrhythmias. But they both have their shortcomings, which you should remember. So I'll just finish with this poem. Some say the world will end in fire, some say in ice. From what I've tasted of desire, I hold with those who favor fire. But if I had to perish twice, I think I know enough of hate to say that for destruction, ice is also great and would suffice. Thank you very much. Anybody have any questions? Yeah, Ross.
I'll speak up. How are we best to impact surgeons who do maze procedures and call it a maze procedure but don't really do a maze procedure?
There's a lot of.
I don't think there's any way to limit free speech. So
I think every PVI gets listed as a maze procedure, and it affects the credibility of what we're doing. I think the cardiologists see that a lot of these procedures fail. People don't do the right lesions, or they don't do complete lesions, or they don't, 1 minute with cryo doesn't create a great transmural lesion. So I know the societies are trying to impact guidelines and things like that. How do we convince our colleagues to be more complete?
yeah, I think that's a real $1 million question. And since I've not been successful over the last 15 years in making that stop, I'm probably not the guy to answer really that. I wish I had an answer for that, Ross, but it's a big problem. And honestly, we've really shot ourselves in the foot as a specialty because of that. And it's interesting because I'll go give a talk at some places and the cardiologists will come up to, we've just never had any of these work. And then when I talk what they're not doing a maze or even anything close to it. So, we've tended to list all procedures for ablation for AFib as a maze or a variant of a maze. There's been so many little hyphen mazes, mini maze, endo maze, it goes on and on, so I think we should really, in the present consensus statements, there's a limit what the minimal you'd have to do to be a maze, but it's still not being accepted. And, I think also in a lot of the journals, they haven't been as strict to make people use it right. People still don't use it right. So, I think it's just education. Interestingly, probably the best thing that happened was when they approved after the trial that AtriCure run and they finally approved the devices, they only approved them to do a maze for. And the FDA said that you can't just sell the devices. You have to teach people how to do the ablation leads instead, because they didn't believe anything else would work with it. So I think some of the industry-sponsored education courses have made an impact on that. But I think as surgeons, and I'm totally open to the fact and believe that definitely not all patients need a full maze. But we just have to be right with the nomenclature, and we should have been better right from the beginning. But, you know, it would be like if we called everything we did in mitral repair, you know, if we had called the whole procedure as a quadrangular section of the posterior leaflet, even if we did anterior leaflet work, or, you know, we'd be so totally confused now. But that's sort of what you did. The mazes is an extensive operation. We shouldn't have done everything. But right from the beginning, people were calling everything a something hyphen maze, and I think it's been to the detriment. I think it's getting better, and a lot of the consensus and guideline statements have really tried to emphasize that, but I mean, I think it's still very confused among cardiologists, very confused.
You're supposed to be required to draw all the lesions that you've created, although I think that's an incomplete worksheet that gets done commonly.
Yeah, well, it's not that easy. You know, we did one of the multi-center trials that I was PI of. You know, we tried to train everyone to do the whole maze. Then we went back and looked at ablation time, and, you know, about half the procedures, they didn't have enough ablation time to even have done a maze, even in a clinical trial. So it's harder. It's like the usual thing with surgeons. We all think we kind of know the right way to do it, and, you know, there is. But, you know, and personally, I don't care how anyone does it, as long as you follow the patients and make sure that it works. So I would have to say, just pulmonary vein isolation alone with the bipolar clamps, we have over time has failed on. I had one patient who was still in sinus rhythm at 8 years, but 8.5 years he went back into AFib. So we've had, as you go longer, it gets very close to 100% failure. I'll show you even leaving one lesion out of the maze, which we did originally, has resulted in really a high late failure rate. So you just have to watch it, but the problem is most surgeons probably aren't following their patients long enough to know if what they're doing works. And I think it's tough because a lot of the cardiologists are very skeptical of what we do. And people always ask me, like, how do I start a lone AFib program? I said, the first thing you have to do is cure your mitral patients. If you could send most of your mitral patients back in sinus rhythm, believe me, you'll get patients. They'll be astounded. But if you're failing on all the patients they're already sending you or not doing it, you're not going to forget about a loan program. I mean, first learn how to do it in the easiest way, which is the ideal way, which is on bypass.
I think that's a good segue to your next talk.
Yeah.